who is Dr. Astrid Wings. Dr. Wings is the Chief of Renal Pathology at Mass General Brigham, covering both Mass General Hospital and Brigham Women's Hospital. She is very interested from a research perspective in the pathogenesis of acute nephrotic syndrome and on podocyte injury and minimal change disease and FSGS, and has made some major advances in that field in the last couple of years. She's a wonderful speaker, wonderful teacher, and very happy to have her back again at our course this year. Thank you, Dr. Wings.
Thank you so much for having me. I hope you can hear me okay. So I'll be covering nephrotic syndrome today. So usually we do that first and the other one next, but we've reversed it this year. So it's a little bit interesting because you probably have already heard some of the things I'm going to mention in the beginning from Dr. Renke, but it's good to reinforce a little bit more about podocytopathies and podocytes in this talk. So I'm the Chief of Renal Pathology here at Mass General Brigham, but I also have a pretty active translational research program and a lab that focuses on understanding acute nephrotic syndrome. So I consider this my area of expertise. So if you have any questions regarding these, please feel free to contact me after, and you can see my email on the left here underneath my picture. Okay. These are my disclosures. And the objectives of this talk will be to briefly review glomerular structure with an emphasis on the glomerular filtration barrier. We're going to use some case-based discussions to highlight specific histopathological findings in diffuse podocyte injury. And then we'll also work on correlating histopathologic findings with known etiologies in minimal change disease and in membranous nephropathy specifically. I know there are a lot more diseases associated with nephrotic syndrome. We will not cover all of those, but I think this should be very focused on podocytopathies, primary podocytopathies. So again, the glomerular structure, you've probably heard a lot about this already today. Obviously, the cell types that are important here is really the epithelial cells, of which we have visceral podocytes and parietal epithelial cells. And the spaces we're going to talk about mostly is mostly the glomerular filtration barrier. And you see a picture of this down here where you can see the podocyte foot processes, every other one coming from the same cell. You can see that here beautifully with this bridging picture. So alternating foot processes, interdigitating from two neighboring podocytes, then the basement membrane, of which you can see mostly the lamina densa, which Dr. Renke has just covered beautifully in this previous talk, and then the endothelium, which is a fenestrated specialized endothelium on the inside. So this really composes the filtration barrier, and everything we're talking about today affects this specific structure predominantly on the outside, the podocyte side. So these podocytes are really crucial to the filtration process, and if they're absent, you almost certainly get proteinuria of varying degrees depending on how diffuse the injury is. The podocytes are special because they're terminally differentiated. Just like neurons, they're post-mitotic cells. They cannot divide and they cannot be replaced. You're born with a certain number as a human, and you lose them throughout a lifetime at varying degrees, leading to probably in your later years some FSGS and some nephron loss, but usually it is not enough to really cause any functional problems. But when more than you expect to be lost during age are lost, then you end up with FSGS, with scarring or global sclerosis and significant proteinuria. So what we're talking about today affects not really the cell body so much, but it affects this structure here. These are the interdigitating little foot processes or tertiary processes, and the way they are structured, the way they interdigitate with each other, and the junctional complexes that link them together, which are the slit diaphragms. Here's a typical transmission EM image of a normal glomerulus. You can see here again beautifully lined up like little soldiers, those little podocyte foot processes here. and you can see again, every other one comes from the same cell. And that's basically showing you the interdigitation, like two hands, the fingers interlocked with each other. And between them, you can see here the slit diaphragms, which are normally present between these processes. And then again, you have a normal glomerular basement membrane and a normal fenestrated endothelium here, which lines the capillary lumen from the inside. This is an endothelial cell nucleus and a cell body, which you sometimes see kind of hobnailing into the capillary lumen. And on the left here, you see the actual cell body of the podocyte with the nucleus as well, and the primary processes that then give rise to the smaller processes that cover the outside of the basement membrane. Again, what we're focusing today on are these foot processes here that sit on the basement membrane and the little slit diaphragms that are formed between them, which actually is more of a network of proteins that link podocytes together, similar to what you see in other cell types where you have desmosomes, for example, linking together the epithelial cells, the keratinocytes, for example, on the skin. The molecular architecture of the podocyte foot processes is incredibly intricate and very important and highly organized. So you have different compartments within even these tiny foot processes, which range in size between 100 and maybe 300 nanometers in width. And the slit diaphragm is about 30 to 40 nanometers in width. So it's this really tiny, tiny structure that you can really only appreciate by electron microscopy. But again, in this small, tiny space, we have a lot of proteins acting together in concert. And any little alteration of this protein network and these protein-protein interactions can lead to very dramatic consequences that result in proteinuria. So as the first thing, we have the slit diaphragm complex. The main proteins here that you should remember are nephrin. Nephrin is actually a very, very crucial slit diaphragm protein, which is a transmembrane protein that actually is cross-linked between cross-links two nephrin molecules cross-link two podocytes in the slit diaphragm complex. So really they're acting in concert with the adjacent nephrin molecule, and then they're linked together with the cell cytoskeleton through podocin and other podocyte proteins that are very specific to the slit diaphragm complex. So this actually gives rise to the slit diaphragm, which you can see is not just one protein, but a bunch of different proteins forming a network of structures that really kind of keep the protein inside and also keep the spacing between two podocytes incredibly constant. So this is very, very important to remember. The next thing is the actin cytoskeleton, which is also highly organized by very specific actin cross-linking proteins. Synaptopodin is one of them. This is a very podocyte-specific protein. It's only found in neurons other than in podocytes. And alpha-actinin 4 is a specialized alpha-actinin that actually links these not only together, but also to the focal adhesion hubs down here, where the podocyte is linked to the glomerular basement membrane. So the cell matrix interaction is also very important, very tight, but also somewhat movable. So if podocytes need to move, they can actually move back and forth and left and right if you want on the basement membrane. But mostly they are very tightly linked to specific matrix proteins of the glomerular basement membranes. And then finally, you have very specialized channels that actually allow for calcium influx into the cell. And the calcium actually is a very important regulator of actin dynamics in the podocyte. And so any changes to any of these proteins, which we know from genetic diseases, from familial forms of nephrotic syndrome, for example, these proteins are all very important in maintaining normal podocyte homeostasis and normal plasticity and normal function of the glomerular basement membrane. and glomerular filtration barrier. So today what we're covering are podocytopathies, primary podocytopathies, which really are connected by the feature of diffuse podocyte injury. So what I'm covering today is minimal change disease and primary FSGS. We'll talk a little bit about collapsing glomerulopathy, but not too much. And then we'll also talk about membranous nephropathy. I put it in brackets because it's not really often linked with all the primary or diffuse podocytopathies, but it is related, and that's why I think we should cover it here as well. So case number 1 is a 41-year-old man that presented to the emergency department with a sore throat, and they made a diagnosis of an upper respiratory tract infection. So this is often what happens in these patients that later present with acute nephrotic syndrome, specifically in children, that they present with some kind of an upper respiratory tract presentation. 2 weeks later, this patient notices swelling in his legs, and this quickly progresses to total body swelling and anasarca. And then he's referred to your clinic by his PCP because the PCP noticed he has very high proteinuria on dipstick, 4+ to be exact. And in your office, the urinalysis shows a protein to creatinine ratio of 15 grams per gram creatinine, so incredibly high in the nephrotic range. He denies NSAID use of any other medication, or use of any illicit drugs, and there's no significant past medical history other than this preceding upper respiratory tract infection. The physical examination is unremarkable except for the body weight, which is up from his baseline weight 3 months ago, and also significant edema of the lower extremities. The urinalysis that I mentioned has high proteinuria and a little bit of blood, which sometimes you can see, mostly in kids. In adults, it's mostly a contaminant in this particular case. And then we have some other values like a creatinine, which is mildly elevated of 1.5. All the immunological testing is negative, ANA, ASO, the sedimentation rate, SPEP, UPEP are also negative for paraproteins. And then a kidney biopsy is performed, usually in adults, to figure out what is going on. Why does this patient have nephrotic syndrome? So here you can see the PAS stain, which highlights the basement membranes very nicely, and also the mesangial areas. Overall, this glomerulus looks really normal. There really isn't much architecturally wrong with it. To the trained eye, maybe some of the podocytes look a little bit reactive, but really this is a normal looking glomerulus with no significant light microscopic abnormalities. And then when you look at the tubules, you can see that there are a few protein reabsorption granules present in the proximal tubules. So the patient has high proteinuria, so this makes sense that he would also reabsorb some of this protein in the proximal tubules. The immunofluorescence shows this picture. So the IgG shows some like subtle granular staining, and it's not really associated directly with the basement membranes. It is kind of like out in Bowman's space, a little bit removed from the basement membrane, but it's really exclusively on the outside of the capillary loops where the podocytes should be sitting. So you're thinking, okay, this is some kind of a granular podocyte staining, but it seems very subtle, too subtle for membranous and not close enough to the basement membrane for a membranous pattern. You see similar staining with kappa and with lambda, and you don't see this staining with albumin, but you do see albumin staining, very coarse, granular, regular staining in all the proximal tubules, telling you the albumin stain worked. It's actually recognizing albumin, but you don't see this fine granular staining with the albumin antibody. So you're thinking, okay, there's some kind of an IgG with kappa, with lambda, so a full immunoglobulin that is depositing somewhere in the area of the podocytes. And then you receive your electron micrographic images back, and you see here on the left upper hand is a normal glomerular filtration barrier that I showed you earlier, just for comparison. And here you can see that when you look at these capillary loops, you see a relatively normal looking endothelium, right? Here's some red blood cells showing you that this is the inside of the capillary, but the outside does not look normal. You don't see the little podocyte foot processes. You see very, very flattened and retracted foot processes that are completely diffusely effaced. Okay, this is diffuse foot process effacement, some microvillus transformation of extra plasma membrane that's sticking out into the Bowman space, and otherwise absence of any recognizable foot processes. So this is what we call diffuse foot process effacement. When you look a little bit at higher magnification, you also recognize, and the asterisks here mark the basement membrane just for your orientation. This is the capillary lumen. This is the urinary space. And here you see these completely absent foot processes with basically retracted and simplified epithelial structure. And what you also don't see, and this is important in this context, are the slit diaphragms. What you see are essentially tight junctions or very, very dense connections here between some of them. And in other areas, you see that the podocytes are not touching each other and actually have lost the slit diaphragm between them. So this is an important feature, slit diaphragm loss along with diffuse foot process effacement. Otherwise, you can see that there's maybe some tubular injury. The tubules are a little bit distended, often in adults more than in kids, but you see this picture with acute nephrotic syndrome a lot. You can see that the brush border is not staining with PAS, telling you that there is some injury to the proximal tubules more than the distal tubules. So there's an element of acute tubular injury with vacuolization here as well on the H&E, and even a few mitoses. So the diagnosis here that you can make as a pathologist will be a diffuse podocytopathy with minimal glomerular changes. So we would call that minimal change disease, and acute tubular injury as well, which is often associated with this and probably accounts for the creatinine rise in this patient. And we've actually seen patients going all the way to anuric kidney failure just due to the presence of nephrotic syndrome. So what is really going on here? So let's take a step back and talk about what podocyte injury really means and how it happens, and what we know now about podocyte foot process effacement, slit diaphragm loss, and the immunological basis for this disease. So intact foot processes, you can see here on the left, right? This is basically a schematic depiction of the barrier structure that we see by transmission electron microscopy, if it's done well like here. And this correlates with the interdigitating foot processes that we see when we actually look by scanning electron microscopy from the urinary space onto the podocytes, right? The interdigitating finger-like processes. And if you cross-section them, you get this kind of picture with the slit diaphragm in between. When podocytes are effaced, these normal little finger-like processes are being retracted back into these primary or secondary processes. So they become larger, the fingers disappear. So the whole structure becomes a little bit more simplified, right? And this is what you're seeing here. And what you're also seeing is this band of actin filaments, which usually runs alongside or inside those finger-like processes as this little structure here on cross-section. It looks obviously a little bit round in the middle here in the center. This collapses completely and is then lining here the basal side of the podocytes, right? So this is all the collapsed actin that you don't have anymore inside the foot processes. So this is what happens in foot process effacement. But this is not all that happens, because I told you earlier that it's not only the foot process effacement, it's also the loss of the slit diaphragms, which are normally present. So this is a normal podocyte here on the left, which, basically allows for, a small pore system to form. And a small pore system will allow for effective reflection or retention of albumin, which is negatively charged by the negatively charged endothelium and the negatively charged glomerular basement membrane molecules. So it gets held in the bloodstream under normal podocyte structural conditions. However, when you have, on the one hand, this complete effacement where you have podocytes lying flat on the GBM, causing more filtration, pressure in these areas, increased hydraulic conductivity, to be specific, and then causes an ineffective reflection of these molecules, because in the areas where you lose your slit diaphragm, that's where all your water can get out. And it's so much pressure here that it actually takes these negatively charged albumin molecules out of the bloodstream into the urinary space. And the negative surface charge will be no longer sufficient to hold them back in the bloodstream. So it's really important to remember that you need both the crazy diffuse podocyte foot process effacement along with the loss of the cell-cell connections to actually cause this degree of albuminuria, right? And you can see this, you can visualize this in a biopsy. This is actually a kidney biopsy from a patient with minimal change disease. And you can see how these simplified structures without the foot processes extending from there any longer, you can see that they're actually moving apart in a lot of areas, causing these clefts between the two cells, right? And this is exactly this condition where you see or these localizations where you see the water basically gushing out along with a lot of protein that cannot be held effectively in the inside of the capillaries. So this is what causes this severe albuminuria we see in patients with diffuse podocytopathies. What do we know about this? We know that obviously these patients mostly respond very well to corticosteroids, which is, an immune-based drug, although we don't know exactly how it works in this condition because it doesn't really explain. It's not explaining this effect, but there is a very rapid effect of corticosteroids in most cases, especially in kids. You treat them and within days or even hours sometimes they get better. But what we do see is we see frequent relapses, we see steroid dependence in some patients, and in some patients, unfortunately, obviously, they become steroid resistant, and you're going to use more immunosuppressive agents that are more powerful to control this disease. What we do know also is that B-cell targeted therapies like rituximab have really, really helped and revolutionized the treatment of these patients, especially those that are becoming frequently relapsing or steroid dependent. And it's been quite effective in those patients, suggesting that there is a potential autoantibody mediated etiology since they're mostly targeting B cells, and B cells produce antibodies. So this is something that was kind of thought about, although there were other concepts also talking about rituximab having a direct effect on T cells as well, although that has become a little bit more, but a little less important in this context. And then we know that memory B cells are selectively increased in patients with steroid-sensitive nephrotic syndrome. This is work that was published by some groups in Italy mostly. And then further evidence for B-cell involvement came actually from historical cases of minimal change disease or nephrotic syndrome, where kids were hospitalized for nephrotic syndrome, and then measles epidemics would rage through the hospital wards, and they would be miraculously cured. And why? Because actually, as it turns out, the measles virus will affect B cells, right? Will cause B cell depletion and immune amnesia, and will eliminate those cells and the production of potential antibodies that cause nephrotic syndrome. So this is all, you can all read this up in old papers from 19 20s and 30s and 40s. It's really quite interesting to read these case reports. So what antigens have been proposed for these kinds of antibodies over the years? So this is not a completely new hypothesis. People have always thought, well, maybe this could be an antibody, but it didn't gain much traction because these antibodies were not seen in the biopsies because people didn't look enough and people kind of dismissed certain things. They were looking for things like membranous, where you see big antibody-antigen complexes. That's obviously not here, and that's why this was sort of like existing on the sidelines a little bit of all research that was happening in minimal change disease and FSGS. But people have looked at that, and I've identified different antibodies to different cellular components that are present in podocytes. There's a couple papers on UCHL1 in kids and in adults. However, this has cytoplasmic or nuclear localization and is not expressed in normal glomeruli. So it's a little bit unclear how this protein should be a target of antibodies and lead to the development of nephrotic syndrome. There's a paper about annexin A2, again, a cytoplasmic, but also membrane-bound phospholipid binding protein. This was identified by mass spec and 2D electrophoresis, but again, this paper lacks a little bit of scientific rigor, so we're not exactly sure if this is real or not. Then there was a paper that was a mouse model only, where they immunized mice against this protein called CRB2, which is actually a protein that's also affiliated with a genetic disease of FSGS in kids. And it's a junctional transmembrane slit diaphragm protein, which might be a target of antibodies causing nephrotic syndrome, and it does that in a mouse model. CD40 has been briefly mentioned more in recurrent FSGS contexts as a cell membrane ligand protein that might be targeted by antibodies present in patients with recurrent FSGS. And then nephrin is really the one that has garnered the most interest in the last few years. Started out with our paper from my lab in 2022, and then followed up by some beautiful studies in the New England Journal and in KI from Tobias Huber's group in Hamburg, where we all showed basically that we can find antibodies against nephrin in patients with acute nephrotic syndrome, both in patients with minimal change disease and also to a lower degree or a lesser degree in patients with primary FSGS and recurrent FSGS in the allograft. And then finally, we have some newer studies from Italy, from Paola Romagnani's group, where she identified antibodies to podocin and also NEF1 or KIRL1, which are also slit diaphragm proteins. But these have not yet been widely recognized yet, although there might be something to this as well. So nephrin really has gotten the most attention and makes the most sense. And I will just walk you a little bit through our findings so you understand how we got to this point. So I showed you earlier in this patient's biopsy, we did see some IgG, which did not resemble the IgG distribution we see in membranous nephropathy. It was a little bit more diffuse, a little bit more subtle. And this, as it turns out, we see quite frequently in minimal change disease biopsies. I would say between 60 and 70% of our biopsies of patients with minimal change disease show this feature, this very faint, subtle staining in podocytes for IgG. So this is specific because we know we see it also in lambda and kappa staining, meaning this is a whole immunoglobulin. It's absent with albumin. So this is a quite specific feature that's now also being reproduced in a lot of other labs. So people have noticed it and seeing it more. And when you actually look at this patient that I showed you earlier with these clefts, you can see that this IgG is actually kind of exactly present in the distribution that is linked to the slit diaphragm. So you see the cell-cell connections here, and where you have a loss of cell-cell connection, this staining is kind of present on either side of those two podocytes. So this is actually very nice because this made me think for the first time that this is an antibody that might be directed against a junctional protein as part of the slit diaphragm complex. when you look at this staining and then do a co-localization study with nephrin antibodies, so you can actually incubate this with IgG and with an antibody against nephrin, and then you actually see that these two antibodies co-localize as evidenced by the yellow pattern. So this is very nice because this really confirms that these patients exist in the same space, and we can even see that it's very closely associated by using this technology called structured illumination microscopy, which allows us to look at even greater resolution at the slit diaphragm. And you can see those proteins line up quite nicely, the IgG and the nephrin at the cell-cell connection. So this is really what sort of proved to us that this is an antibody directed against nephrin, which is part of the slit diaphragm complex, is an essential member of this complex. If removed or if altered, the patients would present with nephrotic syndrome, as we know from genetic diseases in kids with nephrotic syndrome of the Finnish type that are born with congenital nephrotic syndrome because they have an absent nephrin. Nephrin is absent from the slit diaphragm. So what we then did is we were looking for these anti-nephrin antibodies in circulation as well. So we got serum from these patients from the same day or around the time of the biopsy, so we could correlate it with our biopsy findings. They were all in active disease, and we tested them for anti-nephrin by an indirect ELISA that we built in our lab. And we found that actually all of the IgG positive minimal change disease patients also had circulating antibodies against nephrin in their serum. And all the ones that did not, and we included also other controls, including patients with diabetic nephropathy that were nephrotic or other causes of nephrotic syndrome, such as amyloid, those all were negative for circulating anti-nephrin antibodies. So this really showed to us, okay, people with this feature also have anti-nephrin antibodies in circulation. And then we asked the question if they would be absent in remission. So if these patients were positive in nephrotic syndrome, they should be negative when the disease is being successfully treated. And this was indeed the case, as we could not find detectable levels of anti-nephrin antibodies in complete remission. This was basically reproduced by this group in Germany around Tobias Huber, and they found a little bit of a higher percentage in patients with minimal change disease than we identified in our original paper. We had found about 30% of patients were positive, but we had a lot of patients that were already pre-treated in the study because they came from the Neptune study cohort. So they had a little bit of a purer population, and they were able to stratify nephrotic from non-nephrotic patients, and also those that had received no immunosuppression. And as it turns out that in adults, when you look at the ones that are nephrotic, you already get a much higher percentage of positivity, going from about 40% to 60%. And those that didn't have any immunosuppression at the time of testing, at the time of sampling of the blood, they had an even higher prevalence of about 70%. So this matches really nicely with our biopsy findings. 60 to 7% of our patients, 60 to 70% of our patients are positive on the biopsy as well. And in kids, this is even more dramatic. It goes up from 50 to about 80 in nephrotic kids. And those that didn't receive any immunosuppression at the time of sampling had up to 90% of positivity for anti-nephrin antibodies. So really high numbers of children with idiopathic nephrotic syndrome are positive for anti-nephrin. And it was also confirmed that, for example, membranous patients and control patients did not have significant prevalence of anti-nephrin antibodies. So there is a proof of causality, which happened in immunization and passive transfer models by the Huber lab. They basically injected mice with nephrin peptides of the extracellular domain of nephrin, which is the target of the antibody. And they noticed that after about 2 weeks, they started developing antibodies against nephrin, and then also developed at the same time, they started developing albuminuria and other features of acute nephrotic syndrome. And looking at the tissue from those animals, you can see that the nephrin immunized mice have the same phenotype as our patients with loss of slit diaphragms, this kind of like moving apart of the cells, the podocytes from each other, causing some gaps in coverage and foot process effacement. And they also showed that nephrin immunized animals had a higher degree of nephrin phosphorylation, which has already been linked to more proteinuria in other studies. And then they even did a passive transfer models in rabbits as well, where they used serum from an adult with minimal change disease, and they were able to induce minimal change disease in rabbits, and actually found a similar kind of a punctate staining in rabbits as well. So this kind of confirmed our findings in animal models, which is important for really understanding the causality. So the same patient that I showed you earlier was unfortunately, one of the patients didn't do well with just corticosteroids. They had persistent lower extremity edema, hyperlipidemia, and nephrotic syndrome with persistent proteinuria here. And this patient developed what we know as focal and segmental glomerulosclerosis. You can see this here, which is a non-specific term for segmental scarring of a glomerulus, or consolidation. Here you can see several areas where you see connection of the parietal epithelium to the tuft, which happens when an area is devoid of podocytes. So the podocytes have basically all left the premises in these loops here, and then the parietal epithelial cells are trying to cover these segments to ameliorate the proteinuria that happens. And you can see still some podocytes here, which look incredibly reactive, even a binucleate form here with nucleoli and everything. So the podocytes are still unhappy. And now this patient has developed primary FSGS. This is an early presentation of primary FSGS. You can see even like cell debris here, which might be podocytes that are on the cell surface here, or on the glomerular surface here, which are basically undergoing apoptosis or cell death. And when you do a cytokeratin stain, you can see that actually there are all of a sudden cytokeratin positive stain cells that are covering the tuft, which are the parietal epithelial cells, which are activated, okay? They normally are not positive for this marker, as you can see over here. So C3 showed a little bit of nonspecific staining in areas where you have this consolidation of the tuft and the scarring. This is nonspecific entrapment of IgM, a large Ig molecule, which will be entrapped underneath the glomerular basement membrane when you have a lot of protein and water flow through a not so effective filtration barrier. And when you look at the EM, it looks exactly like what we saw in minimal change disease, with very diffuse foot process effacement, right? And still lack of glomerular slit diaphragms. Here you can see it even better, similar to minimal change disease. There's really virtually no difference in the EMs when you look at a preserved glomerulus in a patient with primary FSGS and acute nephrotic syndrome. So this is still a progressive, or still a diffuse podocytopathy, which is progressive and shows some features of podocyte loss followed by early focal and segmental glomerulosclerosis. And there might be even some collapsing features in this patient. And this is just to show you that there is this continuum of morphologic patterns that we can see even in the same patient. We can see normal looking glomeruli that have features of minimal change disease. We might be able to see some that have features of FSGS, as shown in this patient. And we may even see occasionally glomeruli that show collapsing features, as shown here, with very severe podocyte loss and very severe injury and protein reabsorption granules. Still, all of these are considered podocytopathies, and they can be seen together or separate, and all show nephrotic syndrome as a cardinal symptomatic feature, okay? And this really points out to you, or should point out to you, it points out to me as well, that you need maybe a disease-initiating mechanism. For example, antinephrin antibodies. It could also be a toxin that injures podocytes diffusely, right? And then you need something that makes this injury persist or progress, right? This could be environmental. It could be a genetic underlying vulnerability of podocytes that make them less likely to recover and remain more susceptible to the pressure and the injury, and they might jump off or be pushed off the basement membrane. And then obviously other predisposing factors, such as, for example, APOL1 high-risk alleles in African patients or patients with African ancestry, that might make the podocytes to begin with more vulnerable. And then if you add an injurious mechanism such as antinephrin antibodies to them, they have a very severe, much more severe outcome than patients without that, right? So this is how I see this and how I approach these cases now in my clinical practice as a renal pathologist. So we have other common diagnostic patterns that we can see. So I just went over minimal change disease. I went over focal and segmental glomerulosclerosis, which really is just a result of podocyte loss in this particular context. So it's a pattern of injury, which you see by light microscopy, but really is a result of podocyte loss and segmental scarring of a glomerulus. And then collapsing glomerulopathy would be the absolute, worst scenario, where you have a lot of podocytes dying or detaching from the glomerular basement membrane, as in response to a injurious condition. That could be any disease, but it can also happen in patients with antinephrin antibodies. All right. So let's move over to another case. So this is now a little bit different. So I've told you about minimal change disease, antinephrin antibodies, acute nephrotic syndrome. This is now a 63-year-old man who presents with ankle swelling also, improves with a diuretic, but doesn't completely go away, which is what often happens. People are older and they might be seen by their PCP, and a PCP might think, oh, it's the heart, I'm just going to give them a diuretic. But what's really later recognized is that this patient has a very low serum albumin of 2.5, has high cholesterol, has a lot of protein in the urine, and has a high 24-hour urine protein excretion of 9.7 grams per 24 hours. So this is obviously nephrotic syndrome as well. And again, a renal biopsy is performed. So in this patient, we don't know how long this has been going on. It doesn't say anything about, is this acute, or is this something that sort of developed over time, maybe? But often this is what happens in these patients. They might not present as acute. So this is already a lot more developed than what we saw in the previous case, where this was an acute hit on the podocytes. This is more like something that builds up over time. So you see here that when you look at this glomerulus, they're very thickened basement membranes, right? This is very different from the last case that looked almost normal. So we have these thickened basement membranes. We have fuzzy look of the basement membranes on the outside, and a lot of already scarring, actually, of the tubular interstitium, which can or cannot be there depending on how long this has been going on. Focusing on the glomerulus, we see that, again, this fuzziness of the surface of the capillary loops here, the thickness of the basement membrane, right? You start seeing some irregularities with little holes in them and little spikes going outward into the space. And also the podocytes are not happy, right? They're looking like they're very activated and kind of have this basophilic appearance, this purplish look. So they're definitely not happy with the situation here, okay? And here you can see these little spikes that are pointing outward into the urinary space, sort of underneath the podocytes. So the podocytes have to sit on these kind of pillars now instead of the actual basement membrane. So you can imagine that they're not happy because they can't attach themselves as well as they would like to. And the IgG kind of looks like the negative pattern of the silver stain, where you see little granular deposits following very closely the basement membrane. So this is very different from the pattern we saw on minimal change disease with the IgG staining, where it was kind of diffuse and subtle and more in Bowman space where the podocytes are actually sitting. This is looking like it's very closely associated with the basement membranes, right? And much more coarse granular, at least in this more advanced stage. It might be more subtle in patients that have just very early a membranous nephropathy, but in this particular patient, it's really nicely developed. And this is what we mostly see in our patients when they get biopsied, when they are fully symptomatic. The C3 can be positive, can be negative. Here it's mildly positive in the same distribution as the IgG. And oftentimes these patients have a dominance of IgG4 subclass. And this IgG4 subclass can co-localize with a protein called PLA2R, or phospholipase A2 receptor, meaning that this protein is part of these IgG complexes that we see along the basement membrane. So this is the case in about 60 to 70% of patients with primary membranous nephropathy that we see this positive staining for PLA2R along with staining for IgG. The EM looks very fundamentally different from what we saw in the minimal change disease. You also get loss of foot processes, right, in this advanced stage for sure. But even early on, the podocytes get, unhappy because they can't attach themselves to these big complexes, right? They only can attach themselves to the basement membrane matrix. So they're building matrix between the deposits, right? This is why you have these pillars of glomerular basement membrane between the deposits, which are sitting underneath the podocytes on the outside of the capillary loop, on the outside of the GBM. So this is the original GBM here. And then you see the spikes of the GBM, and in between those dark structures are the immune complex accumulations that are sitting underneath the podocytes and pushing the podocytes away from the basement membrane. Okay, this is what's happening in membranous nephropathy, which is what this is. So this is a membranous nephropathy, stage 2, with lots of well-formed immune complexes that are separated by basement membrane spikes. The spikes you saw on the silver stain, the complexes you saw on the IgG stain. And in this particular patient, they are PLA2R positive, meaning these patients have antibodies against the phospholipase A2 receptor. So in the last few years, about 15 years or so, we've learned a lot about membranous nephropathy, right? We've now identified so many different antigens that can form these complexes, but by far the most common one is PLA2R. And these antibodies against PLA2R might be circulating in the bloodstream, and then they get filtered because IgG is filtered through the basement membrane. It's actually small enough to get through, and it usually gets reabsorbed by the proximal tubules. But it hits its antigen partner at the base of the foot process, and then these foot processes keep building up instead of being expelled into the urine, because it happens on the base of the foot process. So this is where the immune complexes build up over time, right? They are trapped between the podocytes and the basement membrane, and they just keep building up as long as you have antibodies circulating. And it only stops when you stop the antibodies from circulating and from attacking or attaching themselves to their antigens. And here you can see an early phase of a membranous nephropathy. You see these two little deposits here, maybe some even tinier ones here. At first, they're being just pushed into the space underneath the basement membrane, and then they kind of start building up, and they're peeling the podocyte off of the surface. You can see it here beautifully. This would be a stage 1 membranous nephropathy with no spike formation yet, right? But you can see how this happens, how this is peeled off. And then at the same time, you see an intact slit diaphragm just right above this. So this is not attacking the slit diaphragm directly. This is really just building up, peeling the podocytes away from the GBM. This is a mechanical problem more so than a functional interference with the with this particular complex. We now know about a lot of different antigens. By far, the most common ones are PLA2R and NEL1. And then we have a bunch of others that we can test for. The best way to test for all of these is sending specimens for mass spec by Sanjeev Sethi over at Mayo Clinic. We do that when we don't have antibodies that we can stain for. We can now stain for PLA2R, NEL1, and exostocin. Some people have managed to get other stains to work, like THSD7 alpha. We have not gotten this one to work yet, but we're working on it. But I think as more of these molecules become available as antigens and for testing should be done, because as you can see here, they're actually associated with very specific things like NDNF. We've had several cases are associated with syphilis. So you might want to know this, that your patient might have syphilis and develops membranous as a result to that, or might have a tumor or a systemic autoimmune disease or a stem cell transplant that might have caused this particular pattern of injury. And again, you have slower disease progression than in acute nephrotic syndrome with minimal change disease, and long persistence of these immune complexes in the glomerulus. And if you have a lot of changes in big immune complexes, you will almost certainly see no complete remission in these patients, because they will always have some degree of proteinuria because of the severe structural deficiencies of their basement membranes or filtration barrier. So again, PLA2R is by far the most common one, followed by exostocin, followed by NEL1, followed by THSD7 alpha, and semaphore 3B is more common in kids. There are different antigens we can test for, and again, mass spec is by now the gold standard for this. So at the end of my talk, I have two interactive questions for you to see if you paid attention. The first one is this one, which is the target protein of the newly discovered and validated autoantibodies in minimal change disease is a component of the A, glomerular basement membrane, B, podocyte actin cytoskeleton, C, slit diaphragm, or D, focal adhesion complex. So let's see what you guys are saying, if you paid attention. Give it a few more seconds. Okay, and here's the answer. Nephrin, and that's obviously an essential component of the podocyte slit diaphragm complex, right? Not the actin cytoskeleton or any other area of the podocyte. Okay, I have another question. I don't know if we are already here. The most common autoantibody target in membranous nephropathy is A, NEL1, B, phospholipase A2 receptor 1, C, double-stranded DNA, or D, nephrin. This should be easy to answer. I think this has trickled down to a lot of people by now. Okay, I'm giving it a little more time, but it looks very clear. The answer is pretty clear, with a few people saying double-stranded DNA, but most people say phospholipase A2 receptor 1, which is the correct answer. And here are the references. And this is the end of my talk. Thank you so much.
All right, excellent. Thank you very much, Dr. Weens. So we're going